Welcome to the conference session titled Predisposition to MDS Pediatric. Thank you for joining us today. My name is Derek Admana, Marketing Coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation in the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get all questions. When asking questions, I respectfully ask you do two things to help you manage the incoming questions. First, submit your question all at the same time. Second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your healthcare. Today's specialist is Wlodarski. Dr. Wlodarski earned his medical degree from his medical degree and PhD from Charité Medical School, Humboldt Universität zu Berlin in Germany. He completed a graduate research fellowship at the Cleveland Clinic before returning to Germany to complete his residency and fellowship at the University Children's Hospital in Freiburg at St. Jude. Dr. Wlodarski studies myelodysplastic syndromes and bone marrow failure syndromes, leading a clinical study to improve the diagnosis and treatment of hematological diseases. With that said, welcome, Dr. Wlodarski.
Thank you very much for the introduction, Derek. I'm very honored to be here for at least three reasons. So reason number one is I'm very honored to be here at a conference that is organized for the first time in Memphis. It's a virtual AMDS conference, and this conference is raising awareness about AA, MDS, and PNH. And also, I'm really honored to see the bone marrow failure and MDS programs growing in Memphis. The adult BMF MDS program led by Dr. Swapna Felda, and the pediatric bone marrow failure MDS program led by myself. Number two, I am very honored and grateful that this conference is organized by a patient group association. And finally, number three, I am extremely grateful to all of you patients and patient families for supporting us in the research and also participating in this conference. I have no disclosures, and this is the agenda for today's talk. First, I will introduce into the differences between pediatric and adult MDS, and I will also talk about basics for the germline predisposition. Then in the second part of my talk, I will give you an overview of germline MDS predisposing conditions. And finally, I will give a few practical examples, specifically on GATA2 and SAMD9 disorders, because these are the diseases that my group is focusing on. So just a brief introduction into MDS. Many of you know that depending on the stage of the disease that we diagnose the patient in, we can call it as a pre-malignant or a malignant disorder that affects the blood production. This disorder is characterized by stem cell failure with cytopenias. So you see that there is a bone marrow failure aspect to MDS. These patients with MDS are at increased risk for clonal evolution towards leukemia, specifically acute myeloid leukemia. And in the bone marrow, we see abnormal morphology of the marrow stem cells and progenitor cells. The overall incidence in adults is over 20 per 100,000 individuals in the population older than 70 years old. So you see that in adults, it's mostly a disease affecting the elderly. The MDS is rare in children, so below 18 years of age. The incidence is about 1, or maybe sometimes, depending on the center, 1 to 3 per 1 billion of cases. On the right, you see a scheme for blood production. So on the top, there are different hematopoietic stem cells. The LT is long-term hematopoietic stem cell. The ST is short-term hematopoietic stem cell. And then we have multipotent progenitor. So we know that the germline predisposition affects every cell of the body. So the germline predisposition will be found in the early hematopoietic stem cell. Then when the patients progress to a more advanced disease, chromosome abnormalities can be acquired in the bone marrow and also somatic mutations. I will talk about it later. So when this happens, the myeloid compartment of the bone marrow expands. So myeloid meaning the, as you see here on the left, this can be megakaryocytes, erythroid lineage, neutrophils, and monocytes. Now, the main differences between children and adults are that in children, the pediatric MDS is a rare disease. It's below 5% of all pediatric hematological malignancies, whereas adult MDS is a more common disease. It's about, it constitutes about 15% of all hematological malignancies in adults. The categories of adult MDS are quite complex, so I have a hard time keeping up with all the classifications, but I can tell you that there are several categories. For example, MDS with single lineage dysplasia or multi-lineage dysplasia, whereas in children, the categories for MDS are quite simple. Children with MDS with less than 5% of blasts in the marrow, these children have a diagnosis of refractory cytopenia of childhood, whereas children with increased blasts in the marrow, and by blasts, I mean the malignant cells, have excess, are called MDS-EP or MDS excess of blasts. Then when we look on the right, in the third box from the top, in adults, MDS with ring sideroblasts is quite common. In children, it's basically non-existent. Then in adults, the bone marrow is usually hypercellular, whereas in children, we see hypocellular marrow failure because it heavily overlaps with the bone marrow failure phenotypes. And then finally, the MDS with deletion 5 and mutations in p53 are common in adults, whereas in children, we see mostly MDS with monosomy 7 and deletion 7q. So these words, monosomy 7 and deletion 5q, they mean that the chromosomes are altered in the bone marrow. So for example, for monosomy 7, we lose one of the chromosomes in the stem cells, and these stem cells have some type of survival advantage and can outcompete the other stem cells in the marrow, but they are also pre-malignant, and at one point they can lead to leukemia. Now, finally, the genetics of adult MDS is quite well understood. Most of the patients carry somatic mutations, somatic meaning they are acquired in the bone marrow. And the germline mutations are more rare, but we are now discovering over the past few years, we are discovering that actually germline predisposition also happens in the adult population. So for example, DDX41 germline mutations are present in at least 1% of all cases with adult MDS. Now, on the left, you see that the genetics of pediatric MDS is mostly focused on the discovery of germline mutations. Most patients have germline mutations. The most common ones are GATA2, SAMD9, 9L, and RANKS1. By germline, I mean that every cell in the body is affected. It can be either inherited from one of the parents, or it can also arise de novo in the embryo during the pregnancy. The treatment for children is mostly curative. If they need the treatment, some of the kids can be watch and wait because they are stable and don't need transfusions. However, if patients need transfusions or have infections, the curative approach would be always hematopoietic stem cell transplant, abbreviated here as HSCT. Now, there are also differences in MDS, how we call the MDS in terms of what was the initial disease. So primary versus secondary. So for the secondary disease, as shown on the right, the secondary MDS arises after a pre-existing problem. So for example, it can be therapy related after the patients have received chemotherapy, specifically alkylating agents or topoisomerase inhibitors, for another condition earlier in life, for example, for a solid tumor or for leukemia. And this can arise many years after the initial tumor has been treated. Then we know that secondary MDS can arise after acquired aplastic anemia, In children, we know the risk for that is about 2%. In adults, it's probably higher. And finally, we know that secondary MDS can arise from inherited bone marrow failure syndromes, specifically Fanconi anemia, Schwachman-Diamond syndrome, congenital neutropenia. Now, on the left, you see that primary MDS is a MDS that manifests as a primary disease. So these patients might not have any pre-existing symptoms. Most of these are idiopathic, meaning we don't really know the cause, but it is reasonable to assume that many of these are in fact caused by germline genetic predisposition. So now when we look at the germline predisposition in pediatric MDS, we know that GATA2 gene is affected in 7% of patients, SAMD9 in 8%, and RUNX1 and others in less than 1%. So I think it is reasonable to call this a subgroup of patients MDS with germline predisposition. And this is actually now reflected in the new categories for MDS. We have the MDS with germline predisposition subcategory. Now, one of the most important questions that we are asked by our patients is why germline predisposition leads to MDS or leukemia. I think it's generally difficult to find an answer for this question, but you could speculate that because of the root of the tree here shown here is affected, or the root in the bone marrow, the stem cells, this is affected by inherited gene mutations. You don't have the leaves, so you lose the leaves or the blood cells. This is the beginning of the disease. And then over time, in analogy to NASCAR race, if you look at that car that is driving too fast and for a long period of time, it gets beaten up. So similarly, in the bone marrow of these patients, the remaining stem cells are lost over time. They have an exhaustion and they might have dysplasia. This is what the pathologist sees under the microscope. Again, in analogy to the NASCAR car that is beaten up and looks like it's not a new car. Now, let's go back to a little bit to our high school or college classes. You all probably remember the Gregor Mendel. He is the father, or maybe now grandfather, of modern genetics. You know what is a Mendelian disorder? So that's basically the basis for Mendelian disorder is Gregor Mendel. And he was a monk working in a monastery or living in a monastery in Germany over 160 years ago. And his passion was to cultivate pea plants. So he cultivated in his work that he published, he cultivated nearly 30,000 pea plants and established 30,000 hybrids by crossing the pea plants. So this work has established the dominant and recessive inheritance that we are now using nowadays when we talk to our patients in the clinic and we tell them what is dominant, what is recessive. And I will come to that in a second. Now, as a side note, I looked up today in the morning. I also found that Gregor Mendel was a geneticist, biologist, meteorologist, and mathematician. So quite many passions. So his work has established this recessive and dominant inheritance based on quite simple but yet repetitive analysis of 4 systems of the peas with 7 phenotype features. So you see from left to right, he looked at the seeds, at the flower, at the pea itself, and then at the structure of the pads. And based on that, he knew that there are 2 types of inheritance. Basically, one is autosomal dominant. So this is a family with an autosomal dominant gene mutation, meaning only one of the 2 chromosomes is affected. The mother, usually in this situation, we would expect that the mother has a clinical phenotype, meaning she is sick. But sometimes we see that, especially in these autosomal dominant disorders, there might be a so-called variable expressivity. That means even if you have the mutation, you might not have the disease. Nonetheless, here you see that statistically speaking, about 50% of our children will carry the same gene. However, this is only statistics. In reality, we see families with 4 children, none of them have the gene, or 5 children and 4 or 5 have the mutation. Now, here on the right, you see the autosomal recessive inheritance, where both of the parents carry a heterozygous meaning only on one of the chromosomes, one of the gene copies is affected. they carry a mutation on the chromosome. And that mutation doesn't cause a disease because you still have a normal gene copy. However, if one of the children has both of the gene copies that are mutated, they will develop disease. And statistically speaking, it's about 25%. Now I would like to move to an overview of genetics and phenotypes of germline MDS predisposition syndrome. But before I get there, I would like to introduce you to the general concepts for diagnosis and therapy of pediatric bone marrow failure and MDS. So it is important to note that the treatment approach for bone marrow failure and MDS is very dependent on the underlying cause. So it is critical to have an accurate diagnosis. And this diagnosis must be reached quickly in some conditions, for example, aplastic anemia, because it cannot wait. The patients are at very high risk for infections. But it can wait in other patients who can be stabilized with blood transfusions, for example, Diamond-Blackfan anemia DBA. We know that the first-line management essentially consists of either hematopoietic stem cell transplantation, if the patient is sick enough and requires the transplant, or specific therapy such as immunosuppressive therapy, prednisone, which are steroids, or androgens, which are derivatives of testosterone. We know that the management has to be tailored to individual patients, and this is what we try to practice in the clinic and have a fine balance between not to overtreat versus not to treat when it's too late. And this is specifically true for hematopoietic stem cell transplant. Now, looking at our genome, so about 1% of our genome are coding sequences. That means those are the genes that make the proteins. And 99% is the dark matter that we don't really understand. The 1% of the genome, the genes, we have about, each of us has about 20 to 25,000 genes. So depending on the study, we now know it's probably 21,000 genes that we carry. And when you look at the germline predisposition to bone marrow failure and MDS, at least 155 genes of this pool of over 20,000 genes is affected and can cause disease. So it's quite complex, but you see here that we have to perform a very detailed analysis of the genome and of these genes to find the diagnosis. So here you see different categories of bone marrow failure syndromes. So Diamond-Blackfan, there are many genes affected, Fanconi anemia, congenital neutropenia, telomere disorders, and so on. I will not go into details right now, but I just want to point to that the genetic causes are quite complex. For the germline, meaning the alteration that is in every cell of the body, we observed coding mutations. Those are mutations in the protein coding sequence of our genes, but we also have non-coding mutations. Those can be regulatory sites in between the genes. Those could be the sites that control the expression of the gene. We also have deletions, meaning one copy of the gene can be lost, either by deletion that is inside the gene or by deletion that wipes out the whole gene. Then somatic, meaning the changes that are acquired in the bone marrow, those are mostly mutations or chromosomal gains and losses. And you have to think from the perspective of evolution. A stem cell that has lost a chromosome, losing a chromosome is an easy task for a stem cell. It happens in our body probably every minute. Hundreds or thousands of cells are losing chromosomes when they divide, but they do not have survival advantage, so they die off. Here in this situation, if you have a predisposition, this chromosomal loss might rescue the bad phenotype that is already happening in the bone marrow. But the problem with that is that it's actually a pre-malignant event, so it can cause leukemia, it can lead to leukemia. And finally, here on the right, you see that the genetic diagnostics is also quite complex. The routine diagnostics that we are performing for our patients in specialized labs are first single gene sequencing. If we know based on the clinical presentation, we know this is most likely a patient with this disease, we will perform single gene sequencing. But nowadays we are moving away from that because it's not efficient, because it would take sometimes months to diagnose the patient if you do single gene sequencing and a stepwise approach. So nowadays we would move rather to a more global approaches to look at the whole lots of genes or whole genome. So one is a CGH or SNP array. It looks for deletions, meaning losses of chromosomal material in genes. Another one is NGS, next generation sequencing gene panels. It's called next generation sequencing because the traditional sequencing was called Sanger sequencing, but nowadays the next generation sequencing is our standard sequencing. So we still use this word, and I think it will be used for a long time. Then we have whole exome sequencing. Whole exome sequencing is sequencing of those 21,000 genes in our genome, which make about 1% of the whole genome. So it's easier to sequence and more cost efficient than sequencing the whole genome. And from the whole exome sequencing, we can look at specific genes that we are interested in because of the patient's clinical presentation, or we can do it unbiased, meaning looking at all the 20,000 genes. But that is very difficult, and I will show you in a moment why. Then the research-based sequencing. In research studies, we are performing whole genome sequencing because for the patients with unknown genetic defect, and where we know that there must be a genetic predisposition based on the family history, for example, we want to identify novel causes of the syndrome. And finally, transcriptome sequencing. This is looking at the expression of the genes, not the DNA, but the RNA. So the RNA is what is transcribed from the DNA. So why I told you before that looking at all the genes in our genome is very tricky, because at the end we will end up with the so-called variants of uncertain significance. So if I sequence any of you today with whole exome sequencing, we will end up with a long list of variants of uncertain significance. And this can make up to 90% of genetic testing results. We know that with every generation, new generation, at least 20 new mutations are acquired in the genome that can actually affect the proteins. So here we end up with a long list of variants of uncertain significance. And that is, of course, probably some of you have also experienced this in the clinic when talking with a genetic counselor, that some of the variants are so-called VUSs, variants of uncertain significance. We cannot call them benign because they are not benign. We cannot call them pathogenic because we don't know yet if they're actually disease-causing. So we keep them under this category. Now, there are certain tricks how to resolve these variants of uncertain significance. So first of all, we are doing segregation analysis. That's why when we perform genetic sequencing, we usually do it on the child and also on the parents to find out if one of the parents might carry the gene, or if the gene is arose de novo in the child, meaning during pregnancy. Then we also perform germline confirmation. That means we are looking for the gene that was, the mutations that was previously found on a blood sequencing panel, sequencing in blood or bone marrow. We want to confirm if it's germline. If it's germline, it would be also present in another tissue, not in the blood, but also in the skin, right? And if it's not present in the skin, then we know it was acquired in the bone marrow only. Finally, functional testing. The functional testing is difficult. It's not established for every gene. Right now, we have functional testing that is very reliable for Fanconi anemia and for short telomere syndromes. Functional testing means you take the blood and you analyze it using a certain method, and you confirm the disease on a functional level. One of the now most important also approaches for solving VUSs nowadays is mining large database of healthy genomes. So NOMAD database is a freely accessible database with over 200,000 healthy genomes. So if you see a variant in your child and in yourself, you can go and see how common is it in population. You can also see how common that variant is based on the ethnic background. So for example, if you're a Caucasian European, you might have a variant that is present, very common in Caucasians, but not present in other ethnic populations. So this might have been a variant that is actually providing some evolutionary advantage to that ethnic population. So that's why we have to resolve the ethnicity as well and look deeper. So there are some certain variants that are, for example, present in South Asians, but not present in all the other populations. So if you look globally, you would think this variant is very rare. It might be pathogenic, disease-causing. But if your patient is South Asian and it is common in South Asian, there must be a reason for that, this variant is probably was evolved during evolution for some certain evolutionary advantage. For example, sickle cell trait that protects from malaria. Now, this is the analysis of over 140 exomes and genomes from healthy people. And you see that based on this, we can resolve the different ethnic populations because we all differ in our genome composition. So variants that are common in our genome are called polymorphisms. And the usual definition, the classical definition for a polymorphism is if that variant is present in at least 1% of the general population. So here, based on this analysis alone, the authors didn't know actually where the individuals came from. So they basically did an unbiased analysis, and based on that, they could resolve the different ethnic backgrounds. So in the middle, the red blob is Northwestern Europeans. Then the blue blob is other non-Finnish Europeans. The green is Southern Europeans. Then on the bottom, you see Swedish and Finnish. They are a little bit different. On the right, you see African Americans and Africans and African Americans. On the top, you see different Asian populations. And this is like this is called two-dimensional map of the polymorphisms in the genome. I find it pretty exciting to look at such data. That's why I wanted to share this with you. Okay, now coming back to our bone marrow failure syndromes that predispose to myelodysplasia. The first classical bone marrow failure syndrome that has been described in literature has been described nearly 100 years ago by a Swiss pediatrician, Guido Fanconi. He looked at a family with congenital changes, so acquired during development, acquired changes, developmental changes of the skeletal system. So these patients had some skeletal anomalies in their arms, and they also had anemia, severe anemia that he called initially pernicious anemia. We know that Fanconi anemia is among the disorders with the highest risk for developing leukemia and tumors. So this is a study from the NIH cohort of patients with Fanconi anemia. On the left, you see the annual risk of developing leukemia, acute myeloid leukemia. It is the highest in children around 10 years old, and then it drops, but this is the annual risk. So we are looking at an annual risk of maximum 5% in this population. And then over time, the annual risk for solid tumors is increasing. So in patients over 40 years, that annual risk is 10%. Now, when you look at the cumulative incidence over time on the right side, the cumulative incidence over time is increasing. So for AML, at the age of 50, you see that the cumulative incidence is, I think, around 17%. That means 17% of these patients who have not been treated with transplant will develop leukemia. And also for solid tumors, it also increases over time. So at the age of 50, the cumulative incidence is about 30%. Now, when we put it into context with other bone marrow failure syndromes, Fanconi anemia is only one of the multiple marrow failure syndromes, but it has high risk for MDS and leukemia. But there are other disorders with also very high risk for MDS and leukemia, and those are severe congenital neutropenia. This is a disorder that affects the maturation of the neutrophils. So the ANC, the neutrophil count, is very low in these children, and they require lifelong therapy with G-CSF every day. And however, they can also be transplanted. Then the Shwachman-Diamond syndrome, which affects skeletal development and also the bone marrow. These patients can have neutropenia, but also other types of cytopenias. And those are the three disorders with highest risk for MDS and AML. Then we're looking at Diamond-Blackfan anemia, which is a disorder of red cells. So many of these patients have absolutely no red cell production and would require lifelong transfusions. And finally, dyskeratosis congenita, which is a disorder of the stem cell. It's a disorder of telomeres. So it's an inherited disorder where the telomeres are lost over time much faster than in our if you're not affected in the general population. And I would like to briefly touch upon this concept of telomeres and telomere shortening. So in 1960, a doctor by the name of Hayflick established that when you take fibroblast skin cells from a healthy person and you culture them over 290 days, at one point these fibroblasts stop growing. And this is usually reached, you see that in phase 2, this is about 40 population doublings, 40 divisions of these cells. They will stop growing because they have reached the so-called senescent phase and end of their replicative capacity. That means they cannot divide anymore. And that's what we know also from other tissues in our body. After 40 cell divisions, it's basically the end. That also defines our longevity. Now, when you look on the bottom, those are the fibroblasts under microscope. The upper picture are normal fibroblasts in the beginning and of the culture, and the bottom one is at the end of the culture. So you see that they are very kind of beaten up and don't look good. So we know that the telomeres are protective sequences at the end of our chromosomes. They prevent that the chromosomes are fused together, and they also make the chromosomes happy. So usually in the aging cell, with every cell division, we shorten our telomeres. But in the patients with this keratosis congenita, this process is much earlier because their function of the telomere components is affected. So there are several genes shown here. I will not go into detail, but these genes are affected and they cause telomere shortening at a much faster rate. So they basically have aging phenotypes in their stem cell and develop bone marrow failure as early as 2-3 years old. Now, the other group of predisposition syndromes that are fairly new are the so-called MDS predisposition syndromes, and there are plenty of them. I would like to start with the PDX41. This is a group of or a gene that causes AML and MDS rather in the adult population, but it can range from even children up to old adults. Anchoring D26, ETV6, you see that it's also rather in the adults. SRP72 ranks 1, you see that it can also affect children. CVPA as well, ETV6, and finally GATA2 and SAMD9 disorder are most common in children. We have identified or established these new syndromes thanks to new genome sequencing methods, which have been available for, let's say, the past 15 years. So most of these genes we know only for about 10 to 15 years. The genes on the bottom, the GATA2, we know only for 9 years, the SAMD9 only for 5-6 years. So we still don't know the full spectrum, phenotype spectrum, meaning clinical symptoms of these disorders. But what we know is that all of them are autosomal dominant. That means only one gene copy is affected. And they can also present without pre-existing problem at any time in life. And they are difficult to diagnose, therefore, because we very often don't know if these patients have the symptoms. We also see the so-called variable penetrance, what I told you before, that when Mendel looked at his piece, not every trait was expressed, even though there was a genetic autosomal dominant mutation. The same we see here. We can have a patient with GATA2, and his parent or her parent is affected by the same mutation, but might not have MDS. How much time do we have left?
45 minutes. 40 minutes.
So 15 more minutes?
40.
I will try to make it brief. Here, please bear with me with this table. This is the summary of new MDS predisposition syndromes. And I would like to guide you systematically through this table. So from left to right, you see the risk for hematologic malignancy, the age at onset, the population at risk, and the reported acquired mutations in the bone marrow in these patients. These mutations drive the development of leukemia in these patients. And then the reported karyotypes meaning chromosomal changes, and finally congenital abnormalities. So for GATA2 and SAMD9 disorders, the risk for hematologic malignancy is very high in GATA2 and moderate in SAMD9. The age at onset for GATA2 in children is 12 years old. When you look at adult cohorts, it's a little bit higher. And SAMD9 it can be as young as children after birth who develop MDS, but it can go up to 18 years, and the median is about 10 years old. The population at risk for GATA2 and SAMD9 are mostly children, but for GATA2 we also see adults. And then you see all kinds of somatic alterations in the genome that are acquired in the stem cells in the bone marrow. And I told you before that these alterations are probably in the beginning, the stem cell selects for these alterations because the stem cell might think this will rescue my problem, which is not growing in the marrow. But at the same time, these somatic mutation can provide a risk for leukemia. That's why it is important to do surveillance of these patients. We do regular checks with the bone marrow and peripheral blood and regular intervals to see if the patients develop these mutations. If they develop them, then it's an easier task to decide for an early hematopoietic stem cell transplant. And then the karyotypes, as I told you before, in pediatric MDS, most common karyotypes are monosomy 7, that means -7 loss of one chromosome. And these two disorders have also, many of the patients have anomalies that were present at birth that didn't affect the hematopoietic system, but other organ systems. And I will talk about it in a moment. Then the second one is RUNX1. The risk for hematologic malignancy is high. The median age is approximately 33 years old for these patients to develop the leukemia. It can be present in all cohorts, from children to adults. And here we see something interesting. The patient has a germline RUNX1 mutation, but some of the patients have also acquired somatic RUNX1 mutation, which is again a sort of rescue mechanism, but it not always works. Reported karyotypes are duplication of chromosome 21 or chromosome 8 and loss of chromosome 7. Now, CBPA is another autosomal dominant disorder with high risk for specifically acute myeloid leukemia, with a median age of onset of about 25 years across all the cohorts found. And here a similar situation where the germline, meaning the mutation that is in every cell of the body, is somehow rescued by additional somatic acquired mutation in the stem cell in the same gene, in CBPA. But there are also other genes that are affected. ETV6 is the risk for developing myeloid malignancy or hematologic malignancy is low to moderate. It's mostly lymphatic leukemias, not myeloid leukemias. It's difficult to predict the median age because of the brevity of the publications and also not many patients affected with this, but it can range from 8 to 82 years, so whole age spectrum. PDX41, this is the most common germline predisposition in adult MDS. The risk for developing malignancy is moderate. The median age is around 55 years and it affects mostly adults. And here we also see an additional PDX41 mutation that is acquired in the stem cell that can provide some drive or some more survival advantage to the stem cell and lead to more leukemic phenotype. And finally, ankyrin D26, and the risk for the malignancy is quite low. This is among actually the lowest risks among the predisposition syndromes. The youngest patients that were reported are 30 years old, and otherwise the risk is quite low. So I think there's the proposed risk for these patients to develop leukemia over their lifetime is about maybe 10 to 20 to 30%. And newest syndrome that was added to this list has been added like about 2 to 3 years ago. It's ERCC6L2 that has high risk for acute myeloid leukemia with M6, so acute erythroid leukemia with a median age of onset of 30 years old and affecting mostly adults. Okay, so now I would like to move to the practical examples on GATA2 and SAMD9 disorders. And I'm very enthusiastic about it because this is what my lab program is studying. So this is a family that I have been seeing a long time ago as a resident in Germany. You see a patient who is 16 years old, who was diagnosed with hypoplastic MDS, hypoplastic meaning no blasts. And she also had trisomy 8, meaning triplication of chromosome 8 in her bone marrow. This is a low-risk chromosome change. So the doctors, because she didn't need any therapy, the doctors decided not to follow her anymore. The hematologists back then in the day, they didn't know that such predisposition can exist. So at one point, this lady was told, "You're cured, you don't have any more disease." However, after 15 years, she developed acute myeloid leukemia with 80% of blasts. So it's a very difficult disease to treat. You can treat it with transplant. So she was transplanted. And she also had trisomy 8 and NPM1 mutation. So that trisomy 8 clone came back after 15 years, and she acquired additional that mutation in the stem cells. Now, around the same time when she was in the clinic, her daughter, who was 5 years old, was diagnosed with MDS, advanced MDS subtype with MDS with excess blasts. So excess blasts meaning blasts between 5 and 19%. So if it would be 20-21%, you would call it AML because it would be leukemia. This girl had monosomy 7 in her bone marrow, so a different alteration of the chromosomes and a different acquired mutation in AS601 gene. And both of these ladies carried germline GATA2 mutation that was present on one of the chromosomes because it's autosomal dominant. And both of them had to be transplanted to be cured. And the transplant was performed at a similar time. Now we know for GATA2 deficiency that children are at risk for developing rather monosomy 7 MDS with around, that risk is highest around 10 years old to until adolescence. Then if you don't develop as a GATA2 mutant carrier, if you don't develop MDS during that time, we believe that the bone marrow cellularity decreases over time. That means the stem cells are lost. And then these patients are at risk for developing adult type MDS or AML at a later age, and specifically with duplication of chromosome 8, trisomy 8. Now, here we looked at, in collaboration with our partners in Europe, who have the largest pediatric MDS cohort, we looked at how common GATA2 deficiency is in pediatric MDS. So we found that looking at a large cohort of patients with, I think it was about 500 patients, we found that 7% of them have GATA2 deficiency. That means the predisposing germline mutation. And when you look deeper into the subtypes, you see that MDS with excess of blasts, these patients had higher risk, higher prevalence. It was 15% of GATA2. We also looked at the changes in the chromosomes in these patients in the bone marrow. So we see that of all the GATA2 patients who have MDS, 70% of them have monosomy 7. So that monosomy 7 association is quite strong here. Now, we looked also the other way around, and that was done in order to help our clinicians who evaluate patients who come to their clinic, pediatric MDS patients with monosomy 7. We wanted to have a prevalence estimate for how common is GATA2 if you see a patient with monosomy 7. So here we see that of 100 patients that came to the clinic with monosomy 7 in the bone marrow, 1/3 of them had an inherited GATA2 mutation. And then we looked deeper. We wanted to know how common is it across different age groups. So you see that in children below age 6, it's very low. It's only 7%. But that frequency of GATA2 carriers that develop leukemia, develop MDS and leukemia increases with age. So in adolescents from 12 to 19 years old, in these teenagers, that risk was very high. 72% of them had GATA2. And also trisomy 8 was another chromosomal alteration in these patients. So we saw that among all the cases with trisomy 8 and MDS, 16% had GATA2 predisposition. Okay, now let's move on to this. And I will not go deep into this table. I just want to point to the 3 columns on the right. So this is a summary of all studies with larger cohort of patients with GATA2 deficiency, with the GATA2 syndrome. And in the 3rd column from the right, you see the age at diagnosis of myeloid malignancy. And across all the studies, it's around 20 years old. So the median age to develop this. So it's fairly young patients that develop MDS if they have GATA2 deficiency. And then we also see. And then we also summarized how common is monosomy 7. 41% of these patients have it, but this is across all the cohorts, children and adults. And again, you see in red font, in red color, you see that in the pediatric cohorts, the monosomy 7 is the most common, from 70 to 80%. Trisomy 8 is in 15% of cases, and it's mostly in adults. Okay, here we summarized all the known clinical features that affect other organ systems in these patients, not only hematology, but other organ systems. So we see an association with autism and ADHD. 12% of these patients have some type of problems in this spectrum. Congenital deafness is found in 7% of patients. Then quite many patients have pulmonary problems, infections, and certain type of disease that's called alveolar proteinosis. Kidney anomalies from birth are found in 12% of patients. Then some patients might have warts, and by warts, I mean lots of warts, like their whole hands can be covered in warts. And that is because they are lacking immune system, specialized immune cells that can kill off these viruses that call warts, and specifically HPV virus. So if you think about it, these patients are also at high risk for HPV-related cancers. That's why it's very important to do early vaccination against HPV. Some patients, some women might have increased risk for miscarriages, and also patients have hydrocele or hypospedia, that's specifically in boys. Hydrocele is like a water sac around the scrotum. Thrombosis was reported in some patients, and finally, quite common lymphedema. This is swelling of the lymph vessels in about a quarter of patients. And finally, immunodeficiency. It's quite common, 40% have some type of immunodeficiency. When you look at all these patients together, any abnormality is found in about half of the patients. That means we will still have patients who have no abnormality at all. They can still have GATA2 deficiency. I think that's important to note for the clinical management. Here on the right, this is a typical picture of a protein. So the protein consists of single amino acids that are these single balls. And the protein goes from N terminus, this is on the left, NH2, to the C terminus, this is on the right bottom, COOH. So this protein, this GATA2 protein, has two specialized zinc finger factors that are important for the function. And we know that the majority of patients have some type of truncating mutations. Truncating means it interrupts the protein sequence, and that protein cannot be produced. And that truncating mutation can happen anyway. It can happen in the beginning, but also later in the protein. Then the second group, in about 30% of patients, is so-called missense mutation. This affects single amino acid, exchanges the amino acids, and it can cause loss of function of this protein. And finally, this is quite difficult to diagnose, but now we have tools to diagnose this type of mutations, are non-coding mutations. I told you before that about 1% of our genome is codes for genes. About 99% is kind of the dark matter, it's non-coding. So here we see some patients, 5 to 10% of patients that might have mutations in these coding regions, non-coding, I'm sorry, and these non-coding have some type of regulatory function. So they might make that gene expression stronger or weaker. So in this case, this is a mutation that weakens the gene expression. Okay, so to summarize GATA2 deficiency, based on the data from literature and our own experience, we can propose this model for natural evolution of the disease. So children that are born with GATA2 deficiency usually have normal cellularity in the bone marrow. That means when you look under microscope, their bone marrow will be normal. They have normal peripheral blood counts and no infections. However, over time, the risk for MDS is increasing, and the highest in children is about 12 years old. So these patients have MDS evolution with certain chromosomal changes, such as monosomy 7 or trisomy 8, and certain somatic alterations, meaning acquired changes in the genes in the bone marrow. Now, if these patients do not develop MDS, if they kind of survive that phase, when they grow old, they have increasing loss of their stem cell in the bone marrow. Now, in analogy to that NASCAR car that I showed you in the beginning, that these stem cells have to drive like 180 and are very exhausted over time. And that increases the risk, obviously, for MDS and AML later in life. So these patients can develop AML, adult type MDS, CMML, and MPN later in life. That can happen at any time in life. We have seen patients as old as 70 who develop the disease. Okay, now to move to the last example of an MDS predisposition syndrome today, I would like to present you this child that we also have seen in the clinic. who was diagnosed at the age of 2 years with MDS and monosomy 7. And this is a little bit different from the GATA2 that I was talking to you before and telling you before, and also different to other predisposition syndromes, because here what we observed here was a sort of natural gene therapy, that kind of a natural miracle that occurred in the bone marrow and cured the patient. So what we saw here is at the age of 2 years, this patient presented with a large clone in the bone marrow with loss of chromosome 7 in 77% of the cells that were examined from the bone marrow. And that chromosome 7 was, what you see here is that's the white chromosome 7 with the red dot. The red dot represents the mutation in SAMD9 gene. That mutation is inherited, and that mutation is bad for the stem cells. So the stem cells try to find a way to escape this bad negative pressure from this mutation. And again, the easiest way for the stem cell when they divide is just to lose the chromosome, a specific that chromosome, and then these cells are selected and expand. So this patient had monosomy 7. However, the family was lost to follow up because they were, I would be scared very much if my child had MDS with monosomy 7. So they were scared, they didn't come to the doctor, to the clinic. And they reappeared for a dental procedure when that child was 6 years old. The monosomy 7 was gone and the blood counts were completely normal. The bone marrow was analyzed for like almost yearly, you see here, normal cytogen. So at yearly intervals, and this girl never acquired any changes in the bone marrow again, and the hematopoiesis, the blood production was completely normal. So right now, this lady is around 30 years old and works as an oncology nurse in Germany. Very, very healthy, has no problems. What happened here was that there was another stem cell, and you see that in the green color. There was another stem cell that what happened was that the right part of the white chromosome broke off in one of the stem cells, and then it was replaced by the black chromosome. So basically, each of the chromosomes comes from one of the parents. So this is a sort of natural gene therapy, because now you have 2 copies of the healthy gene. You don't have the red copy anymore that is a mutant gene, so you have 2 copies of healthy, and this can expand, and we call it uniparental disomy UPT7Q. And in this lady, it was making 60% of the blood production was coming from that one repaired stem cell, which is a miracle, but it happens, and it happens in more patients that we see. So now we know that SAMD9 and SAMD9L disorders are very heterogeneous disorders with different phenotypes. They are also called, SAMD9L was initially called ataxia pancytopenia, SAMD9 was called Mirage syndrome, but now we just call them SAMD9 and L germline syndromes because they can overlap in their clinical manifestation. We don't know much about the genes. We know that the genes are actually responding to pox virus infection and also to viral infections. When the viruses attack the cell is producing interferon, and the interferon can drive the expression of these genes. And somehow this suppresses the marrow to produce more cells. This might be seen as a protective mechanism for the viral infection. We know that these genes act as a tumor suppressor. They're negative regulators of cellular growth, and the mutations that are inherited have negative effect on growth. That's why we have this selection going on in the bone marrow to get rid of that mutation. So all these patients, the unifying phenotype is that they have variable cytopenias, meaning platelet can be low, red blood cells can be low, white blood cells can be low, and they all have high risk for monosomy 7. Now, the mechanism for this somatic rescue or this natural gene therapy is as follows. Again, we have the white chromosome with the red line is the mutant chromosome. The easiest way is to lose that chromosome and expand monosomy 7. However, this is not very curative. We would call it maladaptive because it can cause leukemia later in life. Then we have the somatic SAMD9L mutation, meaning there is another mutation on the same chromosome in the SAMD9 or 9L gene that counteracts the bad effect of the germline mutation. And finally, that uniparental disomy, that replacement of the whole chromosome arm, and this is the true gene correction. So this is adaptive. We have seen this in about 2/3 of patients. Now, the non-hematological features of these patients are also very heterogeneous. I will not go into detail, but some specific phenotypes that we see in this syndrome is ataxia. That means they have wobbly gait, some of these patients. They have atrophy of the cerebellum, means the small brain. They can have smaller head or large head, so it's very heterogeneous. Some patients might have nystagmus, meaning the eyes go back and forth, and also developmental delay. Then some patients have adrenal hypoplasia leading to hormonal problems, hormonal deficiencies, and also disorder of sex development. So, for example, we have seen girls who looked phenotypically like girl, but were actually 46XY. So they had the Y chromosome, the male chromosome. And also low immune system, immune cells, for example, low B cells and low antibodies are seen in many of these patients. Okay, so this is a study that we published last year, looking again in collaboration with the European Working Group on Pediatric MDS. We looked at how common are these mutations in pediatric MDS. And this cover on this journal kind of represents the plasticity of the blood production system or the hematopoietic system, plasticity of the stem cells in children. Because many of these children have these rescue events in the marrow. So you could see it as a very plastic and very flexible kind of rescue event to get rid of the bad mutation. So we studied a large cohort of combined 700 patients, and we found 67 patients with these inherited mutations. Now, this is a very complicated slide depicting the distribution of these germline mutations across the proteins. The take-home message from these results is that there is not a certain region where all the mutations are occurring, and there is not a single mutation causing this disease. So it's very difficult. You see that these genes are quite big, and it's very difficult to figure out which of the mutations are truly pathogenic, truly disease-causing. They are distributed all over that protein or that gene, and also most of them are novel. So you will see a patient that has completely novel mutation, not reported before, not found in the general population. Okay, and here we looked at the overall survival of these patients, because it's important to have some predictive models to tell our families, what does it mean to have SAMD9 or SAMD9L mutation? Does it put you at higher risk compared to the patients who do not have these mutations? So first, here in this study, the overall survival or S, usually in medical studies, we look at the 5-year overall survival. So here you see that the 5-year overall survival between SAMD9 and 9L patients is comparable. So that means comparable means there is no statistical significance. P-value is NS, not statistically significant. If the p-value was below 0.05, that would be still significant. That's what we call significant. But here you don't see a difference. So essentially, overall survivals for SAMD9 patients is 84%, for SAMD9L mutated 93%. But there is an error of margin, and that's why this is not statistically significant. And now when we looked at the overall survival in patients with MDS, refractory cytopenia, RCC, after stem cell transplant, we see that there is that overall survival is independent of the underlying germline predisposition. So you see 3 different colors. The white type meaning MDS patients without predisposition, GATA2 in red, MDS patients with GATA2 predisposition, and in blue with SAMD9L predisposition. So you see that there is no difference in survival between these groups, which is, I think, is striking. That means if these patients are transplanted early, their survival will be similar, independent of what predisposition they have. However, what we see on the right side is that once the patients acquire changes in the bone marrow that are kind of malignant or pre-malignant, such as monosomy 7 here in this case, the overall survival generally drops, but that overall survival is across the 3 cohorts. So the take-home message here is, again, we have to ideally transplant these patients early on in life before they develop these additional changes. And that is true not only for SAMD9L, but also other predisposition syndromes. So that's why we are performing at least yearly bone marrow analysis in many of these patients to look for these alterations. in the bone marrow. Okay, now to summarize this, how the MDS develops in patients with germline predisposition. So we see, number one, every of these children are born with a mutation in every cell of the body. That is the germline mutation, and that can cause restricted blood production. Then number two, over time, clonal selection and expansion can happen. And this clonal selection is facilitated by acquisition of these changes of the chromosomes, for example, loss of chromosome 7 or gain of chromosome 8, or these mutations in these bad leukemia genes that we are looking for by testing on the next generation sequencing panel. And finally, once the cell has gained some malignant potential over time, it can clonally progress to leukemia or advanced MDS. And this is the last part of my talk. I will just briefly touch upon the 2-3 slides on these somatic alterations, the acquired alterations that are present in pediatric MDS and in adult MDS. So now, after 2 decades of discoveries in adult MDS, we know that there are 6 subgroups of acquired mutations in these patients in their bone marrow. And these are the kind of the leukemia driver mutations. So the most common ones are RNA splicing mutations or genes that affect DNA methylation. The less common one are chromatin modification, transcription factors, cohesin complex, and signaling pathways. Now, when you look at pediatric MDS, we looked at, as part of our recent study, we looked at 570 children. We see that the mutations are different. So the most common adult type MDS mutations are not present in children. However, we see some mutations, for example, in the signaling pathways, which are among the least common in adult MDS. So these are common in children. And just to go back here, so let's say we have a patient with different types of mutations. A patient has monosomy 7, the patient has ZPP1 mutation, as you see here, and AS601 and RUNX1, 3 types of mutations. When we do the sequencing in the blood or in the bone marrow, we are looking at thousands or 100,000s of cells. We're looking at the DNA. It's called the bulk sequencing, bulk cell sequencing. So we can't really tell the patient if those are independent clones, independent stem cells that are affected by different mutations, or if it's all acquired in one stem cell over time. So for that, we can establish nowadays very sophisticated methods as part of our research programs, where we can look at the single cells in these patients using a special method called single cell DNA sequencing. So here we can sequence thousands of cells and look for these alterations independently in every single cell. So this is a patient with a SAMD9L mutation, where we wanted to know if the monosomy 7 with EZH, with all the other alterations, is all occurring in one type of stem cell or if it's independent. And in fact, what we see here from left to right, that we have 5 independent clones, 5 independent stem cells kind of producing this picture. So from left to right, we have the native or the normal hematopoiesis in this patient with the germline mutation. Then to right, the revertant mosaicism, the adaptive, the blue is the additional rescue SAMD9 mutation and the uniparental disomy, the gene correction. And finally, on the right, we have the monosomy 7 and the leukemia driver gene. So monosomy 7 alone, which you see on the most right in 9%, 8.7% of cells. And then monosomy 7 with additional leukemia driver EZH2 in 30% of cells. So this patient, we know that this patient requires a transplant because this patient already acquired a leukemia, bad leukemia driver mutation. Okay, so to summarize my talk today, we know that the MDS predisposition can come from classical inherited bone marrow failure syndromes and also from newer MDS predisposition syndromes. And that list is growing because we are developing novel techniques and we are more aware about these novel syndromes. So GATA2 deficiency in SAMD9 genes are most common genetic drivers in pediatric MDS, and these disorders are associated with loss of chromosome 7 in the bone marrow. And finally, mutations are being increasingly detected also in adults. So we now know that about 1% of patients of adult patients with MDS have GDX41 mutation, but the true prevalence is likely higher. So I'd like to thank you for your attention. I'd like to acknowledge my laboratory, Sushi Sahu, Shanice Goodings-Harris, Richa Sharma, and Masa Yoshida. We have created a patient registry for these children with MDS and bone marrow failure syndromes. And on the right, I would like to acknowledge our bone marrow failure and MDS clinical program, which is doing excellent job in providing interdisciplinary care to our patients. And also great thanks to Swapna Tota from UTHCS and Akshay Sharma from the EMT department at St. Jude. And the most important thanks goes to all of you, our patients and families, for bearing with us and supporting our research. Thank you very much.
Thank you so much, Dr. Wlodarski. Really informative. And now we're going to offer up any questions. We do have a couple online, but I wanted to open up here first. So the first question we have online, is there a scoring system like the IPSSS for adults for kids? If no, why? And do you see a future for such scoring system for kids?
That's a very important question that we are asking ourselves very often. I think that the necessity is definitely given because many of these children have different clinical manifestation. So that necessity is given, but such a system does not exist in children. One of the main reasons is that it is a rare disease. So you have seen the largest cohort that we know of, the registry contains about 600 or 700 patients. So I think, and that registry was built over 20 years. So we are trying to have collaborative research across the world with, let's say, USA, Canada, Europe, Japan, to have a fuller picture of these different phenotypes. And I think that there is definitely time to discuss this and how we can use some type of prediction scoring to tell the patient if they need transplant or not. But I think nowadays what we use is definitely the type of germinal predisposition they have, and also the type of the acquired changes in the bone marrow. That helps us, but it's not really well matured.
When should a family consider transplant?
So we have two main indications for MDS, or actually three indications. Indication number one is transfusion dependency, meaning they require regular transfusions for red blood cells and platelets, or their neutrophil counts are very low, putting them in danger for infections. That's number one. Number two is they have acquired chromosomal changes or leukemia driver changes in the bone marrow, and that puts them at risk of developing leukemia very quickly. So that is why we are following these patients regularly and doing these assays. So that's the second indication if they have some changes in the stem cells that are really pre-malignant to malignant. And I think, so that was number one. Number two, and number three is other types of immune deficiency. If they, for example, their lymphocytes are very low, the CD4, CD8 cells are very low, they cannot defeat viruses, that would be also one indication.
Our daughter had a transplant for MDS at age 11. She is now 24 and getting married next year. Should she be concerned about future pregnancies causing a relapse or her children developing MDS? She has an unrelated donor transplant.
That's also a very excellent question. Thank you for that. So if you get a unrelated donor transplant, your blood cells are from a healthy donor, right? So it's not your genomic DNA. If you want to test if you are a carrier of a germinal predisposition of a gene that might be in your eggs or in your sperm, you would have to look either at the DNA before the transplant. Very often it is stored in laboratories. For example, the laboratory that work together with the EMT transplant unit, they do HLA typing. So that DNA is very often stored, so the patients can request it, their own DNA to get it from old repositories. Of course, it's always safe, but some laboratories can release it to the patients. And that's how I would test, either in the old blood or in the skin biopsy. So I think there's certainly a necessity to test and to have a discussion with a genetic counselor because as you have seen, probably at least 20 to 30% of pediatric MDS have germinal predisposition. That means if the daughter had MDS at the age of 11, the risk for having a predisposition in the genes was very high. That means it will be still in her eggs, so that it means she can transmit it to her offspring. So I think that definitely a discussion with a genetic counselor is warranted.
And we have time for one more. Again, I wanted to offer it up. How does the onset of puberty affect an MDS patient? Does it complicate treatment or the disease itself?
So one thing that we know about transplant results, and Dr. Sharma will be talking about it more today, is that the best transplant results that we see are in younger children before the puberty. There is something that is happening in the puberty where there is higher risk for transplants. It's kind of like the teenagers are more like adults, right? However, I think that the transplant outcomes, depending on the disease stage, can still be excellent. Besides the psychosocial burden on the child and on the family, I don't see other problems performing a transplant for a teenager.
Thank you, Dr. Wlodarski, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform for the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform. If we're not able to answer your question today, you can send it to us at any time in 3 ways. First, send an email to help@amds.org. Second, call the AMDSIF helpline at 800-747-2820 extension 2. Third, submit a question on our Facebook page, www.facebook.com/AMDS. If you are watching online, please take a few moments to complete the session survey. Your input is important to us and helps us plan future education programs. We will now be taking a 1-hour break for lunch. During that time, if you are participating online, please visit the online discussion rooms, eat lunch, and chat with others. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AMDSIF Medical Advisory Board and team are here to help you as we have for the past 3 years. This concludes the session.
Yep.